DUPA and retrograde may have similar distributions of hair loss, but their underlying reasons may differ. This is important in some cases because finasteride and dutasteride simply will not work, or at least on their own. Calcipotriol, or like I mentioned previously, clobetasol propionate. Using all of that topically and trying to fight inflammation on various fronts and pathways, that would be potentially favorable for making the tissue come back to a regular state, right? Not making it become inflamed. When you take something like pioglitazone to reduce the, let's say, again for the example, to reduce the lichen planopilaris in that area, that if that disease is gone or limited, that the hair follicle stem cells can replenish the hair follicle organ, and thus you get hair growth in areas that were being suppressed. Before we start this video, I want to give a special shout out to some people. First off, thank you, Frosted Follicles. Frosted Follicles, you brought the attention to a class of drugs known as vitamin D analogs. Not only that, the specific drug known as calcipotriol, and all the research you put on the server, all the discussions you contributed to, believe it or not, it has helped some people. People who have been dealing with psoriasis and scalp inflammation issues. So I just want to let you know, the server and many people in this community, we appreciate you and your contributions because you've helped a lot of people. Up next is Armand from India. Armand, you've been asking for this video for months now, maybe half a year, 6 months. So thank you for the encouragement, and hopefully this video, lives up to your expectations. But really appreciate you for, urging me to write the script and, kind of get this video out, even though I've been sidetracked here and there. So thank you so much. Up next, a special thank you to the people who donated through the Buy Me a Coffee link, as well as the people who became members of this YouTube channel. You guys supported me so much that you threw some bones at me, so I really appreciate that. So thank you. Thank you so much. Next would be the people who joined the Discord server and joined the voice chats. And if you're listening, you should probably join it too. So link in the description. But yeah, everyone who's joined the Discord server and the voice chats, I love talking to you guys. It's always fun. And it makes this online space feel like an actual community of sorts because, we don't only talk about hair loss, but we talk about a variety of topics. So that's really cool. And finally, a special thank you to my video editor, Neil, who's been helping with a lot of videos lately, helping me get these ideas out and saving me a lot of time while I deal with stuff in the real life and other responsibilities. So you've helped my content become very consistent. So I really, really, really do appreciate you. But not to get too sentimental, nostalgic, or even corny, let's get on with the video. Now, before we start this video, please consider sharing this with a friend, liking the video, and of course, subscribing to the channel. And for additional channel support, become a member for as little as $2 a month. But seriously, try not to skip around too much in this video because you'll need the full context to understand everything. As always, check out the links in the description below. I'll get right into the point. Diffuse and pattern alopecia, also known as DUPA, and retrograde forms of hair loss, in my opinion, are more so aesthetics rather than conditions in their own right. This means that people who present with DUPA and retrograde may have similar distributions of hair loss, but their underlying reasons may differ. This is important in some cases because finasteride and dutasteride simply will not work, or at least on their own. To illustrate my point, imagine two people, person A and person B, both missing their right hands. At first glance, their condition might seem identical. However, close examination reveals significant differences. Person A, for example, lost their right hand due to some sort of an accident. An X-ray would show jagged bone ends and possible signs of surgical interventions like pins and plates. There might also be scarring and bone remodeling around the stump. In contrast, person B was born without their right hand due to a congenital condition like phocomelia, where limbs don't develop properly during fetal development and results in stump or flipper-like appendages. Their X-ray would show naturally tapered or underdeveloped bones with smooth contours and no signs of trauma or surgery. Genetic testing would confirm the congenital defect in person B, but not in person A. This distinction that we can see here highlights that an outward appearance can sometimes be deceiving. should we describe the individuals, this person A or person B, having something called missing right hand syndrome? That's just the aesthetic. That's just the appearance. The more accurate thing here to do would be to say that person A is an amputee and person B is just someone with a congenital condition, particularly in this case that I'm giving the example of, phocomelia. Now, let's apply this logic to hair loss, right? Androgenetic alopecia can appear in various patterns, including diffuse unpatterned alopecia, so DUPA. You could have a DUPA that is based in the pathology of androgenetic alopecia. So meaning that DUPA that somebody has, that sort of outward appearance of a diffuse pattern, could be due to a sensitivity of DHT, and this could very well just be a pattern that's being exhibited. The same could possibly be said for a retrograde form of alopecia. Because Hamilton's classification of common baldness, beyond Jun Kim's modification of that Hamilton-Norwood scale, turning it into the basic and specific classification system, and Kamisha et al.'s research on androgenetic alopecia progressions show that androgenetic alopecia can be diffuse or localized to specific areas of the scalp. And that being said, it wouldn't be without reason to say that some patterns are more rare than others, but still the underlying sensitivity or the underlying issue here is that sort of genetic sensitivity to DHT in the scalp hair follicles. So, in other words, if you have DUPA or retrograde alopecia, it could just be plain old androgenetic alopecia. But at the very least, this needs to be fully confirmed because you could have comorbid causes of hair loss caused by other issues. And this is where scalp biopsies are important. So pay attention to this section because this is where you should be getting a scalp biopsy. I'm just going to come in and spoil what I'm going to be talking about in this sort of video, but scalp biopsies will tell you what you're dealing with. So if you're listening to this right now and you want to, just find out what you should be doing, go to your dermatologist and urge to get a scalp biopsy, especially if you've been getting worse while on dutasteride and let's say something like even oral minoxidil. You're using both of those together and you're confirmed getting worse, right? You're doing the trichology reports and tests. You're getting your scalp looked at with a dermoscope. If it is confirmed that you're getting worse or you have any suspicion that it's getting worse, then go get a scalp biopsy. Stop messing around. Stop coping about it. Urge your dermatologist to do it because that's the only way to know what's going on, right? Again, I'm spoiling the video. I'm actually just talking off the script right now because I want you to understand this part in case you're going to skip around. This is what you need to understand, right? Because in a scalp biopsy, okay, they come in, they cut out 4 millimeters of your scalp tissue, and then that area is replaced with scar tissue, right? Okay, you're going to freak out about that. I don't want any scar tissue. But think about it like this, right? You're losing about 40 hairs to tell you the fate of about 50,000, right? So the knowledge you get from that will help you proceed with more effective treatments. So please don't, give a headache in the comments and stop complaining. This is for your own good. So just go figure it out and go do that scalp biopsy. But anyway, let's get back to the original script of the video. So what is a scalp biopsy? A scalp biopsy is a medical procedure in which small pieces of scalp tissue, including hair follicles, are removed from the scalp for examination. This is typically performed in order to diagnose various hair loss and even dermatological disorders such as alopecia, scalp infections, or inflammatory scalp conditions. The procedure is usually done under local anesthesia to minimize discomfort. The area of the scalp to be biopsied is first cleaned and numbed with a local anesthetic. A small circular tool called a punch is then used to remove a core of tissue, usually about 4 millimeters in diameter. The sample includes skin, hair follicles, and underlying tissue like the sweat and sebaceous glands. After the tissue is removed, the site may be closed up with a few stitches or left to heal on its own, but usually they close it up. And depending on the size of the biopsy and even the number of biopsies, because sometimes doctors, if they're really suspicious that one side has a different condition and another side has a different condition, they'll do various biopsies, right? So this also factors the location of the scalp. This would dictate whether or not stitches should be used, or maybe a sort of hydrogel-based bandage, which could be used to limit infections. It should be noted that the area where the biopsy is done creates fibrosis or scarring. But honestly, scarring for losing 50 hairs that probably were dealing with a severe condition or some sort of weird condition to begin with, you losing those 40 or 50 hairs is worth it because it can tell you the potential fate of maybe 100,000, maybe 50,000, depending on how much hair you have on your scalp, right? So this is a good deal. Next, the extracted tissue is then sent to a pathology lab where it is processed and examined under a microscope. Histopathologists look for specific signs of disease such as an inflammation, scarring, or abnormal hair follicle structures. The biopsy results help doctors make an accurate diagnosis and determine the most appropriate treatment plan for the patient. So, scalp biopsies are a very valuable diagnostic tool, providing detailed information that can confirm or rule out conditions that might not be identifiable through clinical examinations alone. And that's just where, the doctor kind of looks at your scalp and says, well, maybe nothing's going on, maybe something's going on. Here, scalp biopsies are a much more elucidative tool to help figure out what the hell's going on and why you may not be responding to a particular treatment. But the thing is, when was the last time you had a scalp biopsy? And, given how kind of invasive, it's minimally invasive, but you can't just always get a scalp biopsy if you feel like you're shedding hair. But seriously, when was the last time you even got one? Just one, which is really all you need. Because most examinations that I've seen, especially when talking to doctors, are done visually, where they just look at your scalp and then they refer to a checklist. Sometimes they use a dermatoscope to check for any obvious signs of inflammation, which is, I would say maybe kind of useful. While, this approach works for the majority of cases, as most hair loss is due to maybe DHT, being the condition of androgenetic alopecia, the literature on biopsies for conditions like, let's say, lichen planopilaris or LPP, shows that it tends to be diagnosed mostly in postmenopausal women. So wait, where am I going with this? Why am I bringing up postmenopausal women? Doesn't that just mean that lichen planopilaris, LPP, this sort of condition that I'm talking about, just affects them? Why do we have to be, so generalistic? Well, we have to look at the literature to see what's actually going on here and why it's kind of misleading. According to Kania-Lepe et al., in the research paper titled, quote, Lichen planopilaris, unquote, by the Stats Pearl publication, the incidence of cicatricial alopecias, being scarring alopecias, is not precisely known. Lichen planopilaris is reported as the most frequent primary scarring alopecia or cicatricial alopecia. That's what, scarring or cicatricial, those two terms can be interchangeable. It accounts for 43% of cases when it comes to scarring alopecias. And they looked at a specific study that involves around 72 patients. And that's where they made that 43% determination. This condition typically affects women, according to them, right, between the ages of 40 to 60, more than men. Up to 50% of patients may develop characteristics of lichen planus lesions. This is another condition that's related to lichenoid tissue or lichen planopilaris. And these lesions affect the skin, mucosal membranes, and even the nails. So sometimes you might see somebody who has lichen planopilaris on their scalp. They might have a defect in their toenails or fingernails. This is also seen in conditions like alopecia areata, where you'll see the patchy hair loss, but you'll also see that sort of issue being presented in the fingernails as well. Why? Because the hair and the fingernails are made out of the same structure. This structure would be the protein called keratin, and this is produced from cells called keratinocytes. So returning back to this sort of article by Kania-Lepe et al., the authors emphasize the importance of understanding the autoimmune nature of lichen planopilaris and its impacts on patient care. However, is it truly the case? Is this paper really actually coming up with a reasonable sort of portrayalment of lichen planopilaris? Is lichen planopilaris primarily a condition affecting postmenopausal women, or is there a strong bias against performing biopsies in men in order to elucidate if that's actually the case, right? Because when a balding dude walks into a clinic, it's often assumed that he has the typical androgenetic alopecia case. From my observations, dermatologists might prescribe finasteride or dutasteride, recommend platelet-rich plasma PRP treatments, and perhaps order some blood work. Maybe. That's probably the most they might even do. And then from there, a diagnosis of androgenetic alopecia is typically given, without a biopsy. In contrast, hair loss in women tends to raise alarms among physicians. Even if it's related to androgenetic alopecia, and with our current statistics, it tends to be, that's the case, that women, if they ever are to have hair loss, it might be just androgenetic alopecia. Conditions like polycystic ovarian syndrome, or PCOS, or menopausal changes prompt doctors to become more involved in diagnosing or figuring out if there's any sort of underlying conditions, right? Because the hair loss might present itself after an underlying condition. So again, this would make the doctor want to investigate more and likely, do a scalp biopsy to see what's going on here. And this is more or less confirmed as a standard practice from a study titled, quote, Evaluation and Treatment of Male and Female Pattern Hair Loss, unquote, by Olsen et al. 2005, which states, again, quote, Diagnosis in men usually does not require a biopsy unless atypical patterns, such as diffuse or female pattern hair loss, or scalp changes indicative of cicatricial alopecia, complicate the case. In women, however, biopsies are more commonly performed to exclude chronic telogen effluvium, diffuse alopecia areata, or early cicatricial alopecia, unquote. Now, this creates a selection bias in the data. Men aren't biopsied as frequently as postmenopausal women. Now, granted, this paper is from 2005. However, the practices are more or less the same today, where biopsies are typically reserved for more obvious and severe cases where clinical signs, quite frankly, would clearly warrant further investigation. So, essentially, what I'm trying to say is, the problem is so bad, at that point, they're just trying to see what specific scarring alopecia that you have, not whether or not you're actually having earlier stages of it. So if we think about androgenetic alopecia treatment, what's the motto, right? Early treatment saves more hairs. So I don't think it would make sense to wait for, to have visible signs of, large scales of inflammation, missing ostas or follicular openings, having that perifollicular inflammation, smooth, discolored skin, and other more pronounced indicators. I don't think it would be useful to wait for things to get that bad when it would be more prudent to do the biopsies in its earlier stages when the scarring alopecia isn't that severe. So again, to reiterate, that kind of approach where you wait until things to get really bad and, the clinical signs are clearly obvious, this often misses opportunities to catch early signs of scarring or autoimmune alopecias, which could lead to irreversible damage if not identified and treated promptly. Because look, it's also the fact that even when you identify that you have a specific scarring alopecia, let's say lichen planopilaris, now you have to find out what treatments will work for you, right? Are you going to take a PPAR-GAMMA agonist like pioglitazone? Do you have to use, in conjunction with that, corticosteroids like clobetasol propionate? Maybe you would have to use calcipotriol to also aid in the de-inflammation process. Even with the thing that I mentioned before, the pioglitazone, the PPAR-GAMMA agonist, you might have to titrate the dose from 15 milligrams up to 50 milligrams because there are some studies that show it being effective at particular doses. And this probably matches with the severity of the cicatricial or scarring alopecia, the lichen planopilaris, because from what we can see in the literature, it seems to be that when there's a defect with the PPAR-GAMMA receptor, this leads to an inability to metabolize lipids in the tissue, and that ultimately results in what? Scarring, because the immune system tries to come in there and destroy the things that are creating those lipids, right? When you have a large amount of lipids in tissue, you get this thing called lipotoxicity, and that initiates the cascade of the immune system coming in and all these horrible secondary and tertiary pro-inflammatory conditions. And this would include the destruction of hair follicles, sebaceous glands, and even the stem cell bulge, where actually you need this structure in order to grow hair. If the stem cell bulge is destroyed, then you no longer have the ability for that follicle, that is, to grow hair. That's just how it is. So really much hasn't changed 20 years later. As of writing this script of this video and recording it, it is January 10th, 2025. So the last study that we looked at from Olsen et al. 2005 was literally written 20 years ago. So when we look at the academic research compilation book by Mohammed Ahmed titled, quote, Alopecia, unquote, published in 2018, it highlights these sort of similar trends, right? Ahmed emphasizes the selective use of scalp biopsies, noting that while they are critical diagnostic tools, they are often underutilized unless the clinical presentation is ambiguous or severe. And this sort of underscores a gap in the current practices where early detection, like I said before, particularly in scarring alopecias, like lichen planopilaris or central centrifugal cicatricial alopecia or CCCA, is not always prioritized. So we really need to take care of these practices and revisit them. And this creates a selection bias in the data, like I mentioned earlier. Because men aren't biopsied as frequently as women, or even postmenopausal women, obviously you're going to have the data suggesting that, oh, lichen planopilaris only affects postmenopausal women. And again, this practice might be underutilized in women with slow progressing hair loss conditions, like a gradual progression of lichen planopilaris that destroys follicles, let's say, over years. And these women might be excluded from biopsy data for a considerable amount of time, right? So again, we have this selection bias in the data. Men aren't biopsied as frequently as postmenopausal women. Additionally, other women who aren't postmenopausal aren't biopsied as frequently. It's only when they get really, really bad, when things realistically can't be reversed that much, that's when they finally, get that biopsy. The point I'm trying to make here is that scalp biopsies should be more common for everyone than they currently are. I'm not saying that everyone should, go in and get their scalp cut out a bit, but I'm saying it has to be a bit more common. Because not only would it help people who have early signs of scarring alopecias, but also it would inform the literature better to give an accurate representation of what's actually going on. We would get actual numbers rather than numbers that are kind of suspect. Now, I talked to Dr. William Rassman, the inventor of the FUE hair transplant procedure, on my podcast, Hair Stacks. During our conversation, Dr. Rassman mentioned that some of his colleagues at the Bernstein Medical Center for Hair Loss Restoration make it a standard practice to biopsy anyone who's potentially seeking a hair transplant. This is done to rule out other potential causes of hair loss besides androgenetic alopecia. Why? Because, well, if you have lichen planopilaris or another scarring alopecia, over time, the place where you're transplanting the hair to, the site of the condition, those follicles are very, very likely to die in about 1 to maybe 5 years. As a side note, this could possibly be why some hair transplants actually fail. Maybe these people don't have androgenetic alopecia. Even if they're on treatment, they could be dealing with an autoimmune related condition, which, let's be real, DHT drugs or anti-DHT drugs like 5-alpha-reductase inhibitors or topical anti-androgens aren't really going to do that much to mitigate. Anyway, Dr. Rassman explained that through this more rigorous analysis, both he in his own practice as well as Dr. Shaver and staff at the Bernstein Medical Center have identified comorbid conditions of hair loss, such as androgenetic alopecia overlapping with lichen planopilaris and even other issues. While there aren't many studies on this topic, some research indicates that women are more thoroughly investigated for their hair loss concerns than men, and we'll look at these statistics regarding that. But right now, I'm going to actually play a clip on the screen where Dr. Rassman kind of talks about this. From some research I've done by looking at the literature, like the early Norwood scales, as well as what we know in recent years about cell lineage differentiation, where DHT-sensitive hairs have different characteristics than more resistant ones, the idea that the type of hair loss pattern in androgenetic alopecia is likely a genetic feature in and of itself, like, say, someone's height or eye color seems to be very reasonable, and some features are more common than others. But in DUPA, it appears to be an aesthetic of sorts. I say this because all it looks like is a diffuse, unpatterned hair loss. There are many conditions like hyperprolactinemia, hypothyroidism, and even some forms of areata, like alopecia areata incognita, that can manifest a DUPA-like condition, aside from androgenetic alopecia. That being said, have you ever recommended scalp biopsies in your practice when it comes to more atypical patterns of hair loss?
Yes, Dr. Robert Bernstein and Dr. Christine Shaver in New York. Dr. Shaver she's a dermatologist, and she had a particular interest in something called lichen planopilaris, which is another disease of the scalp. that causes hair loss. There are a series of diseases of the scalp that cause hair loss, and you don't want to do surgery, hair transplant on people that have fronting fibrosing alopecia or lichen planopilaris or a variety of these other scarring alopecias. So she has made a habit of starting to biopsy young men in two places when she has even a suspicion that there might be some underlying disease, even though it doesn't show very well. And she has found an enormous number of patients have lichen planopilaris, which means that these people, if they had a hair transplant, will fail. Eventually, sooner or later, will lose their hair. So when we look at, I look at my career now 34 years in the hair transplant business, and I used to see every once in a while a patient that would come in 10 years out, 7 years out. I even remember somebody 3 years out that came to me and he had a beautiful head of hair after the surgery. And then all of a sudden the hair started to fall out. And I always sort of think of the hair around the side and back as permanent. It never went away. But at that time, I didn't understand that these people probably had lichen planopilaris and had this autoimmune disease in the scalp. And it was just inactive. And then as they got older, it became active. We find these diseases far more common in women than men. And for that reason, because they're so common in women, the doctors haven't thought of this as a male disease. And yet it is a male disease. And Dr. Shaver is basically writing this up now for publication. So I think that this is an important observation. And so to answer the question, you make that diagnosis.
I see.
I think if I'm suspicious of something, I'll biopsy it.
From what I see on websites like Reddit, people often suspect that they may not only have androgenic alopecia, and because not everyone is getting a biopsy, it could be the case that issues like lichen planopilaris and other conditions are often overlooked.
The problem in the hair transplant industry, and I don't mean to be too accusatory, but there are many doctors that enter this business that just learn how to do FUE and they don't learn dermatology of the scalp. And if they don't learn dermatology of the scalp and the diseases of the scalp, then they're going to not recognize these diseases, and then they're going to transplant these people as they develop balding, and then they're going to fail maybe 3 or 5 years later.
Yeah.
And when they failed in my hands down the road, and this, by the way, in my practice, the numbers that would fail were about 3% that would fail out there in 5, 10, 15 years later. But I'm sure that those 3% were lichen planopilaris, and a diagnosis that was never made. And by the way, nobody knew about it then. It wasn't like I was just a bad doctor. Nobody had talked about it. It was never considered a disease in men. And sure as hell it is.
So, my interview with Dr. William Raspin shows that it isn't a common practice to biopsy men. In fact, Dr. Jeff Donovan, possibly one of the leading hair loss specialists in the world, dermatologist, just all around great doctor. In his article about scarring alopecias, particularly lichen planopilaris, Dr. Donovan states that, quote, one needs to take into account the patient's entire story. If a physician just biopsy every patient that comes into the office, I can guarantee one will make a whole lot more diagnoses of LPP, lichen planopilaris, than truly are present. I'm a big believer in this, even though LPP is underdiagnosed in the world. But listening to the patient's entire story and examining the scalp and reviewing what the biopsy shows, not just the final readout on the bottom line, one can usually get a fairly good sense. However, in rare cases, time is the best judge, as a missed case of LPP will likely declare itself over time. Unquote. You see, and that is the idea. If more scalp biopsies are done, Dr. Donovan and even Dr. William Raspin, these, to use clinical trial terms, key opinion influencers, where they have a wealth of knowledge, they've done a lot to actually contradict the literature and shows where the literature is actually lacking. They point at, something significant, right? This lack of biopsies. But if we do more biopsies, you're more likely to find that the rates in your particular clinic for conditions like lichen planopilaris, frontal fibrosing alopecia, and other scarring alopecias are probably higher than what is represented in the medical literature. In fact, we can refer to a study titled, quote, Frequency of the Types of Alopecia at 22 Specialist Hair Clinics, a Multi-Center Study, unquote, by Vonio, Galvin et al. This retrospective study analyzed previously recorded data, hence the term retrospective, from multiple centers worldwide, covering continents such as Europe, the Americas, Africa, and Australia. This study included a total of 2,835 patients, with 72.7% being female and 27.3% being male, and a reported 3,133 diagnoses of alopecia, with 73% being non-scarring types of alopecia and 27% being scarring alopecias. So a total of 57 different alopecia types were identified. That's a lot. I didn't even know we had 57. Anyway, maybe there were like unique variations here and there, but anyway, the most frequent type was androgenetic alopecia, coming in at 37.7%, followed by alopecia areata at 18.2%, telogen effluvium, which isn't an alopecia, but still it'll be included as a hair loss disorder, being 11.3%, frontal fibrosing alopecia being 10.8%. That's a bit high compared to telogen effluvium, by the way. In any case, moving on from that, lichen planopilaris being 7.6%, folliculitis decalvans being 2.8%, and for those of you who don't know, folliculitis decalvans is when you have a bacterial infection in your hair follicle, which actually causes a scarring alopecia, which can destroy the follicle outright. Next, discoid lupus being at 1.9%, and then finally, fibrosing alopecia in a pattern distribution being at 1.8%. Now, if we are to break down these scarring alopecia conditions by gender, we can get an idea of what's going on here. So, in total, scarring alopecias accounted for 27% of all alopecia cases in this dataset. Among the specified conditions studied included 1. Frontal fibrosing alopecia, and of the 337 total cases, 320 or 95% occurred in women, and 17 or 5% occurred in men. For the condition, also scarring alopecia called central centrifugal cicatricial alopecia, say that 3 times fast, of the 30 cases, 29 or 97% were in women, and 1 or 3% was a man. For lichen planopilaris, of the 239 total cases, 198 or 83% affected women, and 41 or 17% affected men. For fibrosing alopecia in a pattern distribution, of the 57 cases, 51 or 89% occurred in women, and 6 or 11% occurred in men. So, given that frontal fibrosing alopecia, central centrifugal cicatricial alopecia, lichen planopilaris, and fibrosing alopecia in a pattern distribution are increasingly recognized as clinical variants of lichen planopilaris based on shared histological features observed upon biopsy, these conditions can be combined into one broader category. So when we look at all of the alopecia cases and we combined all of the scarring alopecias into one merged condition, right? Let's just call it broader lichen planopilaris variants. In that data set, we can see that there are 663 cases of scarring alopecia, and of these, 598 cases, or 90.2%, occurred in women, while 65 cases, or 9.8%, occurred in men. This combined perspective highlights the significant predominance of scarring alopecias in women, but also underscores the presence of these conditions in men too, albeit at a lower frequency. The proportions of lichen planopilaris and its clinical variants is strikingly high in this study, again with 663 cases representing a significant portion of all alopecias diagnosed. However, it is important to note here that this is only a retrospective study and does not clarify whether all cases were biopsy confirmed. So this sort of limitation is critical because many individuals may have co-occurring alopecia conditions, such as androgenetic alopecia alongside with latent or subclinical scarring alopecias that remain undiagnosed without histological confirmations. But I will say that there likely was a bit of an overlap here too. Maybe there were some biopsies that occurred because you have around 2,000 patients, but then at the same time you have 3,100 diagnoses. So that suggests that some of the patients probably were noted to have more than one condition. But it could very well still be higher. Again, another point we can see here again is this gender bias in biopsy practices. So I don't really see this study actually getting away from the fact that there could be gender bias when it comes to looking at certain hair loss conditions, right? They're just going to biopsy women more because, when a woman comes to a clinic having hair loss, it prompts further investigation, right? Where for a man, they probably have to have some serious sort of, conditions going on. In fact, we don't even have to speculate here because it actually mentions in the study itself that 298 patients, or 10.5%, presented with two types of alopecias at the same time. So that's pretty significant here. But it could still be underpowered. But once again, this isn't beneficial for anyone. So we should adopt more minimally invasive practices like biopsies, right? Or even hell, the KOH test, where they come in, they scrape a bit of your skin, and they examine it. A microbiologist examines to see if there's any features of like yeast or fungus that could be contributing to conditions like folliculitis decalvans, or maybe even tinea capitis, or, more commonly referred to as ringworm, right? These are some tests you can do. Scalp biopsy and a KOH test. I think these tools are very important if you're not getting any sort of progress while on dutasteride or finasteride, especially dutasteride, because that thing wipes out a lot of scalp DHT. So if you're still getting worse, it might be the case highly, at least for you, it might highly be the case that you're dealing with another condition alongside androgenetic alopecia. So consider those two things: scalp biopsy and a KOH test. But we're not done here yet. Let's look at how, biased the literature is to kind of show you guys what's going on here. So in the study titled, quote, Lichen planopilaris in Women, a retrospective review of 232 women seen at Mayo Clinic from 1992 to 2016, unquote, by Sidney C. Larkin et al., published in 2020, here researchers provided detailed insights into the prevalence and characteristics of lichen planopilaris among women. The study found that out of the 232 women diagnosed with lichen planopilaris, an overwhelming 92.7% presented with hair loss, highlighting the commonality of this symptom in lichen planopilaris patients. Furthermore, the study reported that 217 of these women underwent confirmatory biopsies, so it reinforces the importance of biopsies in diagnosing lichen planopilaris. The study also notes that lichen planopilaris predominantly affects women, with a mean age diagnosis of 59.8 years. And that's kind of a weird thing to say because this is a study that's exclusively looking at women, so of course they're going to say that it predominantly affects women. This is kind of like me foreshadowing what actually went on here and why this seems kind of like a weird study. So there was an inclusion of a large number of women who were biopsied, and this shows through their diagnostic approach that, typically is taken for female patients experiencing hair loss. So typically women who are experiencing hair loss, once again, I will explain this over and over again, they will get biopsied more than men. But then the authors state something that was kind of strange. They said this, quote, men were excluded from this study to more accurately determine the association of hormonal factors in lichen planopilaris pathogenesis, unquote. Now, this exclusion removes us from knowing the possibilities of, any potential histopathological differences that lichen planopilaris could have, maybe it could have, in males, or even hormonal factors that could possibly exist beyond DHT. What I'm trying to say is, why did they exclude men from this study? Like, okay, I get it. Yeah, they wanted to see how it was in women, but their premise seemed as if they kind of came to the conclusion already to determine that, well, this condition already affects women. So we're just trying to see, what factors are actually influencing this. But how can they just come out from the get-go by just saying, well, this condition already affects women or solely seems to affect women, so let's exclude men from this research? It's kind of weird. And more importantly, I'm also concerned about the findings that were, discovered in this study. And essentially, it stated that women, or let's just say people in this case, if we're assuming that, men who weren't represented otherwise would have had lichen planopilaris, so people who tended to have lichen planopilaris They were also comorbid with other conditions like diabetes, skin cancer, nutritional deficiencies, and much more. So by excluding the men in the dataset and not having a more robust and rigorous investigation leaves out a lot of people, including, as I've previously mentioned, women who may not be menopausal or postmenopausal, but have a slow progressing scarring alopecia condition like lichen planopilaris, maybe subclinical levels of lichen planopilaris, where you can see the early signs of it, but it's not necessarily fully destroying structures yet. It's still a problem nonetheless, and it should still be addressed while it's still manageable, because once those hair follicles are destroyed, it's going to be, a lot to bring them back, and most of the time they don't come back, especially if the damage has gone on for like decades. Now, let's go in deeper into the literature to understand the nature of the underreporting. In September 2022, a cross-sectional study titled, quote, Prevalence of Lichen planopilaris in the United States, a cross-sectional study of the All of Us research program, unquote, authored by Tejas P. Joshi et al., and it was published in the Journal of the American Academy of Dermatology International. This study aimed to estimate the prevalence of lichen planopilaris across a diverse nationwide sample of U.S. patients. So out of 327,654 people in this database, only 142 were identified as having lichen planopilaris, representing an overall prevalence of 0.043%, with a confidence interval of 95%, of the range, of this percentage being between 0.042% to 0.044%. The study found that 91.6% of the lichen planopilaris patients were, surprise, surprise, female, and members of the white Caucasian race, and they had the highest prevalence, right, of this particular condition. The average age of diagnosis was 62.4 years. Now, once again, we have a very questionable study that is, weirdly done. So you mean to tell me, out of the 327,654 people with hair loss in this database, only 142 had lichen planopilaris? Let me ask you a question. How was this determined? Did every person in this study, in this database, have their hair loss condition confirmed through biopsy in this retrospective dataset? I'm particularly concerned here because if this wasn't the case, then most of the subjects in this dataset were not confirmed through biopsy, but rather through a clinical assessment where the physician simply looked with their eyes or perhaps used a dermatoscope to examine subjects and their scalp, and we may be facing a significant bias in the literature. I believe this bias is further emphasized when researchers ignore data to fit preconceived notions, as we saw in the case from that one Mayo Clinic study, where they were essentially coming from the standpoint that lichen planopilaris already affects women, so let's just throw out the male data. Again, this was seen in that Mayo Clinic paper titled, quote, Lichen planopilaris in Women, a retrospective review of 232 women seen at the Mayo Clinic from 1992 to 2016, unquote, authored by Sidney C. Larkin et al. So this is the huge gap in the literature, and this is probably why a lot of people are having issues with identifying, what their DUPA or diffuse and pattern alopecia condition is, or what their retrograde alopecia condition is, right? Like I did with the example in the beginning of the video. Imagine patient A and patient B, they're both missing their right hands, right? Patient A, it seems like they just got it amputated. Patient B, if I recall correctly, I think it was patient B, they were born with a sort of congenital defect that caused their right hand to be missing, that being phocomelia. So let's apply that logic here, right? When you get a scalp biopsy and even a KOH test, when you have DUPA or retrograde alopecia, what you're essentially trying to do is you're trying to find out if, is my hair loss due to androgenetic alopecia? Does it have the histopathological features of an androgenetic alopecia biopsy? Or does my hair loss have to do with, maybe lichen planopilaris, right? Does my DUPA have to do with lichen planopilaris? DUPA itself is not its own condition. Let's get that through our head. DUPA, diffuse unpatterned alopecia, and retrograde alopecia are not conditions of their own. They are just aesthetics. They are just appearances. In order for you to know what your DUPA is and what your retrograde alopecia is, you need to get a biopsy done to further kind of, make that obvious to you. Don't play any games. Don't waste time. Because some people might say, well, I've never seen anyone respond positively to dutasteride who had DUPA. Yeah, because maybe they had another hair loss condition. Did they get a biopsy? Right? Did they get a KOH test? Maybe they have some sort of fungus or microbe, doing the funny dance in their scalp and eating up their hair follicles. Right? These are things you have to do. And I'm kind of being strict here because I just see these comments all the time where people are like, oh, there's nothing you can do. And then they make up this crazy ass thing where it's like, well, the reason why it's not working for you is because dutasteride raises scalp DHT at 222%. And this means, or they might say something stupid like, oh, it raises scalp testosterone by 5,000%. And that's why you're losing your hair because it's still an androgen. No, that's not the case. Let's just simplify this and make this, much more easier to understand. Dutasteride is wiping away a lot of scalp DHT. So if you're getting worse on dutasteride, that means you have to start looking in other areas because one, time is of the essence. So you have to start getting that sort of scalp biopsy to see what's going on there. You have to get that KOH test to see what's going on. Because I would guarantee you, if you're still losing your hair on dutasteride, it isn't because of high scalp testosterone levels or a backdoor pathway that upregulates DHT in the tissues, or the reflux hyperandrogenicity level, or you becoming more sensitive with your androgen receptors. No. The likelihood here is that you have another condition, right? And I'm going on a rant here. If you notice that you have skin, like pimples on your scalp, if you notice a burning feeling where you're losing hair, like an itchy burning feeling, if you notice these weird plaques or redness on your scalp or discolorations, if you're seeing like white hairs, right, that are coming out of your area of hair loss, if you're seeing these sort of things, this all should prompt you. Even if you feel one thing, a weird itchiness, this should prompt you to get that scalp biopsy. So you might ask me, well, lichen planopilaris, doesn't that have a specific feature? Doesn't it look distinct? No. In fact, it can adopt patterns that are very similar to the Norwood scale. So, we have literature on that too. And that's also worrying. And I want to say this, right? Just to reiterate, having an autoimmune hair loss condition is important just to know for your health, right? Because we have studies. We can refer to a particular study. It's called, quote, Incident, Prevalence, and Co-occurrence of Autoimmune Disorders Over Time and by Age, Sex, and Socioeconomic Status, a population-based cohort study of 22 million individuals in the UK, unquote, by Nathalie Conrad et al., published in 2023, highlights that autoimmune diseases are often co-occurring. So the study found that individuals with an autoimmune condition had a higher risk of developing an additional one later on down the line, or probably having some sort of latent one with them at the moment. So for example, individuals with, let's say, childhood onset type 1 diabetes had a significantly higher rates of Addison's disease, thyroid disease, and celiac disease, which suggests that there are some sort of shared pathogenic mechanisms or predisposing factors among autoimmune diseases. So you can have lichen planopilaris that puts you at risk for having, let's say, for example, Crohn's disease, right? You might also have that. So if you find out you have an autoimmune hair loss condition, whether it's scarring or non-scarring, so an example of non-scarring would be alopecia areata, or whether it's scarring being lichen planopilaris, you should probably get that, first off, checked out. And then next, you should probably check if you have any other co-occurring autoimmune diseases. So, get your body checked, get your entire being examined by a doctor. Now, let's try to understand DUPA, right? What is DUPA? DUPA is diffuse unpatterned alopecia. And I think there's a study that we can kind of look at that can help us understand how DUPA, it's sometimes also referred to as a sort of female pattern hair loss, how it can kind of differ from androgenetic alopecia. So this is the DUPA in the case where it's actually based in androgenetic alopecia. So for additional context, let's look at Kamishima et al.'s paper titled, quote, Divergent Progression Pathways in Male Androgenetic Alopecia and Female Pattern Hair Loss, Trichoscopic Perspectives, unquote. The 9 quantitative trichoscopic factors identified in the study included hair diameter diversity, which measures the variation in thickness of individual hairs within the same area of the scalp. This factor is significant because greater diversity in hair diameter often indicates the presence of miniaturized hairs, a hallmark of androgenetic alopecia. Next, we have hair density, and this is another key factor that represents the number of hairs per square centimeter of the scalp. So lower hair density is a common characteristic observed as hair loss progression, providing a clear indication of how much hair has been lost in a given area. Next, we have the percentage of thin hairs, and this is a critical factor because it evaluates the progression of hairs below a certain diameter threshold, highlighting an extent to which follicular miniaturization has occurred. This factor helps quantify the number of finer hairs compared to the normal, thicker hairs, which is crucial in assessing the severity of hair thinning. So in men, androgenetic alopecia typically follows the patterns of the Hamilton-Norwood scale. The early stages often involve a receding hairline, thinning at the crown, and also vertex. As the condition progresses, extensive baldness occurs in the frontal and vertex regions of the scalp. However, the occipital and parietal areas are typically known as the safe donor areas because these, for whatever reason, are less impacted by DHT. It's just a genetic feature. One of the early signs of male androgenetic alopecia, as described by this paper, is significant reduction in hair diameter. This thinning of hair strands indicates the onset of follicular miniaturization. As the condition advances, the diameter reduction becomes more pronounced. Additionally, there is a decrease in the number of hairs per follicle unit. So, as we know, each hair follicle produces maybe 2 to 3 hairs, 3 to 5 hairs sometimes. Lucky people might get even 6 hairs per hair follicle. So, if you're having a decreased number of hairs per hair follicle, this increasingly leads to single hair follicle units. And this causes a reduction in hair clusters and reflects a decline in overall hair density as fewer hairs are growing together in groups. Now, female pattern hair loss, on the other hand, and, I'll just say this, I'll put this in here, it often kind of adopts a DUPA or a diffuse and pattern alopecia kind of look, is often assessed with various scales. This study talked about the Ludwig scale, and this kind of differs from the traditional male androgenetic alopecia. So, in female pattern hair loss, it typically is the case that you have diffuse thinning all over the scalp and the crown while maintaining a frontal hairline, much like DUPA. So unlike the distinct recession patterns that you see in male pattern baldness, DUPA or female pattern hair loss involves a sort of uniform reduction in hair density across the scalp. So we can really get an idea of DUPA by looking at female pattern hair loss. So if the hair loss is kind of progressing in this sort of fashion, and if you do a biopsy, then you may be able to determine, hey, my DUPA is due to androgenetic alopecia and not any other condition, right? There are some telltale signs that the doctor, if they're good enough, the dermatologist, can see with their eye to kind of indicate that, okay, your DUPA is due to androgenetic alopecia, it's due to a sensitivity to DHT. But if you're still concerned, you can still get that biopsy done. Now, I want to backtrack a bit here, right? As reported by Olsen et al. In the 2005 review paper, quote, Evaluation and Treatment of Male and Female Pattern Hair Loss, unquote, men are biopsied only when they present with a female pattern kind of hair loss. So, again, this overall approach kind of overlooks cases of men who have even pattern forms of lichen planopilaris or even frontal fibrosing alopecia. So what am I seeing here, right? Well, let's look at the study performed by Martin S. Zinkernagel and Ralph M. Trueb, or Dr. Ralph M. Trueb, in 2000, titled, quote, Fibrosing alopecia in a pattern distribution, pattern lichen planopilaris or androgenetic alopecia with a lichenoid tissue reaction pattern, unquote. And this study indicates that even scarring alopecias like lichen planipilaris can present in patterns similar to androgenetic alopecia. Look at that. That's kind of worrying too. So it isn't always the case where dermatologists can just look at the scalp and say, well, it kind of looks like androgenetic alopecia, right? Because it can adopt a sort of manifestation mimicking a norward progression when in reality that person could also have, androgenetic alopecia, but maybe they have more of that lichen planipilaris condition in that sort of Norwood mimicking fashion. So again, yes, what do we do here in this condition? Yes, biopsy. You would use a biopsy to determine whether or not you, as an individual who's getting worse on something like dutasteride, maybe you have this sort of lichen planipilaris that's mimicking androgenetic alopecia. So I'm just urging people here to just go get checked. So let's assume you went to go get a biopsy and now it's confirmed that you have lichen planipilaris in your retrograde alopecia pattern or in your DUPA pattern, right? Let's say your DUPA is now confirmed to be due to lichen planipilaris or one of its variations. So lichen planipilaris is one of the most prevalent forms of scarring alopecias, and this is a group of hair loss disorders that we have to understand this is typically considered irreversible hair loss due to the destruction and fibrosis of hair follicles, primarily mediated by the immune system. The study titled, quote, Scarring Alopecia's Pathology and an Update on the Digital Developments, unquote, by Donna M. Cummins et al., published in Biomedicines in 2021, offers an insight into the pathological mechanisms and diagnostic challenges, as well as technological advancements in managing scarring alopecias. Scarring alopecias include lichen planipilaris, like I mentioned before, but it also is characterized by a destruction of the hair follicle epithelial stem cell niche, also known as the follicle bulge or the stem cell bulge, however you want to call it. This region, located at the lower part of the hair follicle, just above the attachment point of the erector pili muscle, contains epithelial hair follicle stem cells that are essential for regeneration and the cyclical growth of hair follicles. So if you were to destroy this sort of bulge or the stem cell niche bulge or whatever you want to call it, again, if you destroy this region, this leads to permanent hair loss because it prevents the hair follicle stem cells from actually coming in and regenerating the hair follicle, right? These stem cells are important for regulating the anagen cycle. So if they're not there anymore, or if their activity is greatly reduced, then the hair follicle will simply die out over time. Because it is in lichen planipilaris, the inflammation, what we call the perifollicular inflammation, meaning the inflammation around the follicle, infiltrates and targets the bulge where the stem cells live, and after that bulge is destroyed, this leads to something called immunoprivilege collapse. Now, what is immune privilege? So, immune privilege or immunoprivilege is a state where certain areas on or in the body are protected from your immune system. So, it has certain chemical features and properties that essentially says, hey, body, I'm you, don't attack me. But as these sort of features, these chemicals, these signaling pathways kind of die down, the factors that facilitate immune privilege also collapse. And this makes the immune system say, hey, I gotta kill that thing. I gotta come in there and just blow that shit up. Now, there are proteins that typically help identify these organs or body parts to the immune system, and it's called antigens, right? These antigens on the hair follicles say, hey, again, I'm part of your body. But as that follicle begins to die out, as those hair follicle stem cells can no longer facilitate that environment, those sort of proteins kind of dwindle, and then the immunocollapse occurs. And this causes an autoimmune response that damages the hair follicle stem cells and the hair follicle unit overall. Now, for a non-scarring alopecia like alopecia areata, the immune privilege collapse seems to occur at the base of the dermal papilla of the hair follicle. So in this case, there is no actual destruction of the hair follicle as the stem cell niche bulge is not destroyed. So using something like a JAK inhibitor or a topical corticosteroid injection in many cases helps the hair come back, after a while because it's going to suppress the immune response and it's going to allow the hair to kind of grow again, right? Because the stem cells are still kept intact. That bulge structure, the stem cell bulge structure, the microorgan in the hair follicle organ is still there. Also, androgenetic alopecia is a form of non-scarring alopecia, but there is some reason to believe that it eventually becomes a form of scarring alopecia, or perhaps, in my thought, which I will elaborate later, the condition of androgenetic alopecia primarily caused by DHT may be implicated in other hair loss conditions. Now, this is major. I know this has been going on for a while, so please stay tuned. So why did I bring up immunoprivilege or immune privilege, right, and its collapse? Well, it's crucial because it helps us understand why the autoimmune reactions occur and why they may lead to irreversible hair loss. The study by Cummings et al. Highlights that the destruction of sebaceous glands is a common early feature in all types of scarring alopecias before significant hair loss. Sebaceous glands, which are small oil-producing glands connected to hair follicles, play a vital role in maintaining the health and integrity of the hair follicle structure, organ, and just overall the general environment by producing sebum, which lubricates and protects the hair and the skin. And their loss or their dysfunction is considered an early marker of disease activity and can precede noticeable clinical symptoms of hair loss. So, if you get a biopsy because you're complaining about a very itchy, oily, very, very itchy and oily scalp, it could be the case that, hey, we might just, by chance see that, hey, something's going on with this guy's sebaceous glands. It looks like he has a scarring alopecia that's coming up. And what's even more concerning here is that you may not even see that in the clinical, setting just by looking at the scalp, right? Maybe by just taking a biopsy, it can kind of forecast the damage that is yet to come. So when it comes to the types of scarring alopecias and sebaceous gland destruction, in scarring alopecias such as lichen planipilaris, frontal fibrosing alopecia, central centrifugal cicatricial alopecia, discoid lupus, erythematosus, folliculitis decalvans, and pseudopallid of Brock, in all of these conditions, the sebaceous glands are among the first structures to be destroyed. This early destruction is significant across various types of scarring alopecias, indicating onset of irreversible hair loss, and also some similarities more or less, right? Because if we're noticing that it tends to be the case that, well, the sebaceous glands are first destroyed, that can possibly give us an idea on how we can treat it, or maybe some things we could investigate to see what's going on here. So again, I want you guys to keep in mind the significance of the sebaceous glands and sebum production, in general, lipid production, because as we go on with this video, maybe it'll come back and you'll be able to understand, why this is important when it comes to treating a condition, right? So if your DUPA is confirmed to be due to lichen planipilaris, or if your retrograde is confirmed to be due to any of these sort of scarring alopecias, it's probably important to, kind of pay attention to what's going on with sebum. Maybe having high amounts of sebum is bad. Maybe having low amounts of sebum is bad too. Maybe sebum that's rich in these things called triglycerides and cholesterols, right? These lipids can make the environment very prone to being inflamed and fibrotic over time. So now that we know that there's a histopathological similarity between all these scarring alopecias where the sebaceous glands are destroyed and the stem cell niche bulge is also destroyed, what we have to ask is, what's going on, right? Because it seems as if the thing that is doing the destruction are these sort of white blood cells called lymphocytes, where they come in and they are kind of like, agents of chaos. They're designed to destroy infections, but now, for some reason, they're causing this, mass inflammation that is destroying very important and crucial hair follicle structures. Well, let me just say this. DHT-mediated disorders encompass a range of conditions primarily steered by the impact of dihydrotestosterone, or DHT, on specific tissues. DHT is a potent derivative of testosterone, and it is converted by the enzymatic activity of 5-alpha reductase and has been implicated in various disorders, including several linked directly or indirectly to skin health. Primarily, these disorders include prostate issues, particularly benign prostatic hyperplasia, where DHT contributes to an enlargement of the prostate gland, hirsutism, noted by the excessive hair growth in women, often on areas like the chin and upper lip, and this is often indicative of some sort of hormonal disruption, maybe caused by polycystic ovarian syndrome, where the female body tends to produce more androgens or becomes more androgen dominant, and this leads to DHT stimulating hair follicles on the body. We also have, to be honest, what is more related to dermatology for both men and women, seborrheic dermatitis, and this is a skin condition characterized by inflamed, oily skin, which is typically itchy and sometimes presents with flaky skin on the scalp and red patches. The role of DHT, while often discussed, may have indirect implications through sebaceous gland activity, and it could impact and make seborrheic dermatitis worse, or it could be the thing that starts seborrheic dermatitis. Finally, we have the condition androgenetic alopecia, whereby a genetic sensitivity to DHT in hair follicles results in their miniaturization and eventually a halt in hair production. But let's look deeper into the impact of DHT on the skin, particularly in conditions like acne or seborrheic dermatitis, where it is observed that DHT plays a pivotal role in modulating sebaceous gland activity. Now, guys, pay attention here because this is going to get pretty exciting, or maybe horrific, depending on how you want to look at it. In essence, DHT causes the sebaceous glands to overproduce oils that are rich in triglycerides and cholesterol, when typically these oils, in their own normal state, contain specific nourishing components such as free fatty acids and squalene. Consequently, these overactive sebaceous glands produce oils that, when not in balance, can create a conducive environment for clogging of the glands and the skin pores, whereby trapping bacteria. And this scenario sets the stage for conditions like acne vulgaris or cystic acne, whatever, when this occurs on the facial skin, and potentially even seborrheic dermatitis when this occurs on the scalp, right? Maybe even folliculitis decalvans if you're just having, a super sensitivity in your sebaceous glands to DHT, because it'll just keep pumping out oil and you'll become very inflamed with this oil. Now, it's important to mention that the understanding of DHT's involvement and inflammatory interactions with the skin is derived from various scientific studies that explore the biological and clinical aspects of these conditions. These research endeavors examine the genetic predisposition, enzymatic activities, and hormonal levels, as well as cellular responses to DHT and its impact on the skin and hair follicles. So, DHT and its effect on the scalp and skin sebaceous glands. In a pivotal study conducted by King et al. In 1982 titled, quote, "A double-blind study of the effects of 13-cis-retinoic acid on acne, sebum excretion rate, and microbial production," unquote, the impact of 13-cis-retinoic acid, also widely recognized as isotretinoin, was investigated in the context of acne treatment and related physiological variables such as sebum excretion and microbial population on the skin. A particular focus of the study showcased the relationship between sebum, specifically its triglyceride content, and the proliferation of acne. King et al. Provided compelling evidence regarding how isotretinoin plays a crucial role in regulating sebum excretion rate and subsequently the microbial populations, particularly something called propionobacteria or propionibacteria, which are notably associated with lipid-rich areas of the skin. Triglycerides, a prominent component of overactive sebum that causes acne, were highlighted as a significant factor of the growth of these microorganisms, suggesting that sebum, rich in triglycerides, contributes to the proliferation of acne by providing a conducive environment or a rich environment for the growth of this propionibacterium or bacteria, however you want to call it. So once this sebum excretion rate was reduced, it reduced the availability of triglycerides, and this caused the number of this bacteria to decline and ultimately die, and thus mitigating the acne severity. So over here, we can see that the sebum, rich in triglycerides, right? We get the understanding here that it has an impact on the inflammation of the skin to even create an acne. So if you have something that can reduce that sebum, right, that can reduce that high oil production, it could make the skin and the sebaceous glands go back to normal activity. In the next paper we're going to be looking at to inform our understandings is a paper from 2007 titled, quote, Pharmacological Modulation of Sebaceous Gland Activity, Mechanisms and Clinical Applications, unquote, by Clark et al. And this provides an extensive exploration into the intricate mechanisms that seem to underlie acne vulgaris. Again, we see here that sebum impacts the acne, right? Excessive amounts of sebum will lead to the colonization of particular bacteria, Propionum bacteria or Propionum acnes, and the presence of this bacteria causes a cascade and release of inflammatory mediators, which inflames the hair follicle and other skin structures. But I want to focus on something particular in this paper, right? Because when we come to focusing on DHT, Clark et al. Sheds light on how hormonal regulation, especially by DHT, influences sebaceous glands in how they produce sebum. So although they talk about isotretinoin's capability to influence 4 pathogenic factors of acne, impacting the cell cycle progression, cellular differentiation, cell survival, and ultimately apoptosis, they also point out by saying, hey, DHT also impacts the sebaceous glands, so that could be a sort of potential pathway of addressing this sort of acne condition or these sort of, oily conditions of the skin. In the next paper titled, quote, Regulation of Human Sebaceous Glands, unquote, by Danae Tibutot et al., published in 2004, the authors talk about how androgens such as testosterone and dihydrotestosterone work to regulate the sebaceous glands and produce sebum, and they can also cause acne, and how there should be a means of exploring how to prevent them from binding to the androgen receptor, perhaps in the sebaceous glands and sebocytes, in order to treat acne. Again, a condition that has to do with oily production, right? Excessive sebum production. And finally, we're getting to the paper that kind of draws it all in, right? Paper 4. This paper deals with further evidence of DHT inflaming the sebaceous glands, and it can be seen in the mechanism of action when it comes to the drug clascoterone, also known as CB0301, which is a topical anti-androgen used to treat against acne. It is under the brand name Winlevi. So in this pivotal study conducted by Herbert et al. 2022 entitled, quote, Efficacy and Safety of Topical Clascoterone Cream 1% for Treatment in Patients with Facial Acne, 2 Phase 3 randomized clinical trials, unquote, the authors go into showing the potential benefits of using clascoterone 1% cream to mitigate facial acne, further emphasizing its role in how clascoterone inhibits or blocks androgen receptors. So it's really focusing on the DHT androgen receptor pathway. So once clascoterone binds to the androgen receptors, it prevents DHT from binding to it in the sebaceous glands, and this causes a reduction in sebum. However, if this doesn't happen, right, the DHT binds to the androgen receptors in the sebaceous glands, and it tends to overstimulate the activity of the sebaceous glands, leading to excessive sebum in some people. And from this, you have downstream inflammatory pathways that are activated, which can destroy the skin. It can cause for excessive oil production, and this can be harmful. Because if this happens in excess, it could lead to destruction of that tissue. It can cause, scarring. That's where you get the cystic acne, where in some people, the inflammatory response is just very major, because maybe they have a sensitivity, or maybe they're just producing way too much sebum, perhaps due to diet, or maybe due to DHT. Maybe it's just DHT doing that, and it doesn't matter what you do for your diet. If you have that sensitivity to DHT, it's just going to do that, and it's going to make that skin disease worse. So with that in mind, let's look at the relationships between androgenetic alopecia, seborrheic dermatitis, and acne. There was a study titled, quote, The Annual Changes of Clinical Manifestations of Androgenetic Alopecia Clinic in Korea Males and Females, an outpatient-based study, unquote, by Woo Sung-Gyang et al., 2013. And it goes into the complex relationship between androgenetic alopecia, seborrheic dermatitis, and revealing how the latter has a sort of associated condition in both male and female patients with androgenetic alopecia, meaning that it seems to be the case that there's some interplay between people that have seborrheic dermatitis, right? This skin condition, as well as male pattern or female pattern hair loss. So in seborrheic dermatitis, what do we often note, right? We're having this oily scalp. There's, itchiness and scaling and flaking. That's what we're dealing with. What do we know in some acne conditions like acne vulgaris, right? Especially when it's hormonally influenced. We have DHT or 5-alpha reductase activity going on in the sebaceous glands such that there's DHT frequently binding to the androgen receptors in the sebaceous glands, which causes those androgen receptors to produce more sebum. Sebum that tends to be higher in what? Triglycerides and cholesterol. And when this sebum is, very high in the tissue, it leads to inflammation, it leads to itchiness, it leads to the formation of acne. So we can see here, right, these are kind of DHT-mediated conditions. There's a really good argument to make here that DHT could potentially influence seborrheic dermatitis alongside androgenetic alopecia on the scalp. So what I'm trying to get across here, right, is that there's more than kind of, meets the eye here. If we need even more evidence, we can look at another paper titled, quote, Androgenetic Alopecia in Adolescents, a report of 43 cases, unquote, published in 2006 by Byung-Jun Kim et al. And it shows over here that conditions like seborrheic dermatitis, androgenetic alopecia, acne vulgaris, and atopic dermatitis all tended to be related to each other. Once again, what seems to be the connecting factor in all of this, right? It seems to be that it's DHT. DHT stimulates the sebaceous glands in all of these conditions, and it seems as if when you have too much sebum, it causes these excessive conditions. These sort of issues where you're having seborrheic dermatitis, hair loss from androgenetic alopecia, acne from overactive sebaceous glands on your face, and an atopic dermatitis where you're kind of just itching everything. So why is this important, right? Well, when we look at lichen planopilaris, there's this receptor called a PPAR-GAMMA receptor. Now, the PPAR-GAMMA receptor is important because it deals with regulating lipid metabolism in various tissues of the body. Let's just focus on the skin, right? Let's not think about everything else. Let's focus on the skin. So what we've noticed in the literature is that when the PPAR-GAMMA receptor is underactive, when it's downregulated, when it's not doing its job, it causes for there to be a buildup of lipids. This leads to something called lipotoxicity. Lipotoxicity is when you have an abundance of lipids in, let's say, the extracellular matrix or the fluid that surrounds cells. And because you have an abundance of this lipid, over time it becomes toxic, right? So this triggers an immune response where your lymphocytes try to come in and clean up all that lipid garbage and also destroy the cells that aren't really doing their job. So this leads to the lymphocytes just really coming in and destroying everything, right? Because it creates this hyper state of inflammation. And unfortunately, it destroys the sebaceous glands because, the PPAR-GAMMA receptor of those cells aren't really working properly over there. But because we're fostering this, mass inflammation in this environment and you have all this sort of lymphocytes running around, it will pretty much destroy anything where it has the potential to destroy the stem cell niche bulge, where if that's destroyed right, the hair follicle can't grow anymore. It just dies. You can kind of get an understanding of how the PPAR-GAMMA receptor works by looking at a paper titled, quote, Structure of the Intact PPAR-GAMMA RXR Alpha Nuclear Receptor Complex on DNA, unquote, by Vikas Chandra et al. Basically, in order for the PPAR-GAMMA receptor to actually work and do its job in breaking down lipids, first, the PPAR-GAMMA receptor has to be stimulated by something called a ligand. So let's kind of simplify this a bit. For instance, sebocytes, and these are, cells that produce sebum, the oily substance in the skin. This oil, when it's produced, whether it's a triglyceride, cholesterol, whatever, it can either activate or deactivate the production of certain proteins by influencing how the DNA is interpreted, similar to how adjusting settings on a machine can change its output. So here's what happens. The ligand, or the sebum, right? Whatever the sebum oil is, it's floating around in your cells, right? And then it comes in contact with the PPAR-GAMMA receptor. And it should, in theory, activate the PPAR-gamma receptor and cause the PPAR-gamma receptor to bind with the retinoid alpha receptor. And those two things come together to form something called a heterodimer. Now, when this comes together, this structure, this superstructure comes together, we'll call it a super sort of receptor of some kind. It goes into your cells, into this place called the nucleus, and the nucleus stores your DNA. Now, your DNA has instructions for producing various things, right? It says, okay, let's break down, lipids by doing this, right? It's like a playbook of instructions. So you have this joint sort of structure, this heterodimer of the PPAR-gamma and the retinoid receptor, and it's going through your DNA and it's activating key response sites, right? It's activating specific sections of your DNA and it's turning on specific genes that have to do specific things. And these specific things are metabolic functions in breaking down lipids or creating more lipids. Essentially, it would regulate skin health. Now, if your PPAR-gamma receptor is damaged due to, let's say, something environmental, or maybe due to some sort of genetic factor, or maybe, let's say, you just have too much sebum, right? Due to DHT interacting with your sebaceous glands that seems to upregulate the amount of sebum you have, this can lead to conditions like lichen planopilaris. So you can have this sort of weird spot where you have DHT that's stimulating the androgen receptor and causing your hair follicles to miniaturize, but even then, you can have DHT that increases the oil output from your sebaceous glands, such that if you have an underactive PPAR-gamma receptor due to your genetics, or maybe due to an environmental toxin that kind of messed up with your PPAR-gamma receptor, this can also cause hair loss in its own right? The excessive oil production too here from DHT interacting with the sebaceous glands can also cause lichen planopilaris. And this is where I personally see androgenetic alopecia connecting to lichen planopilaris and its other variants, right? This is where I see the DHT thing kind of bridging, androgenetic alopecia and lichen planopilaris, or a non-scarring alopecia with an autoimmune scarring alopecia. And we know that this receptor is pretty damn important, and now we have studies that kind of prove it, right? So in the study titled, quote, PPAR-gamma agonists and their role in primary cicatricial alopecia, unquote, by Sarawin, Harn Chuwang, and Pukait Shanawanit, published in PPAR Research in 2017, provides critical insights for us to understand the role of the PPAR-gamma receptor, or the peroxisome proliferator activated receptor gamma, especially when it comes to the development of lichen planopilaris and other primary cicatricial alopecias that are just derivatives of lichen planopilaris. To once again explain the PPAR-gamma receptor's responsibility, it catches onto lipids, and then it should, with that information, it should stimulate the PPAR-gamma to bind to another thing called the retinoid receptor. But if, once again, the PPAR-gamma receptor isn't working, this is going to lead to lipotoxicity, where gradually, lipids will begin to build up in the tissue, and it becomes very toxic because your PPAR-gamma receptor isn't activating enough to kind of help remove and destroy those lipids. So this fosters a very poor metabolism in the tissue. And once again, it leads to lymphocytes destroying that tissue. So I've been yapping all the time. What can we do to solve such an issue? Well, we need to take something called a PPAR-gamma agonist in this case that would kind of turn on the receptor, the PPAR-gamma receptor, and make it work properly. Now, if you can do this early enough in the intervention of lichen planopilaris, you can potentially save hair follicles. You can potentially stop the spread of lichen planopilaris, if not significantly slow it down. And then over time, you can restore lipid homeostasis, and you can make the sebaceous glands kind of function properly again, and those hair follicles should be able to recover if they were kind of thinning out or dying. So the drug pioglitazone, or commonly known by the brand name Actos, A-C-T-O-S, this drug has been noted in the literature to help reduce inflammation when it comes to lichen planopilaris because it activates the PPAR-gamma receptor. Now, keep in mind, pioglitazone and other PPAR-GAMMA receptor agonists are primarily diabetes drugs that are used to improve insulin sensitivity and regulate blood sugar levels in patients with type 2 diabetes. They are usually prescribed when patients have not adequately responded to other diabetes medications such as metformin or sulfonylureas. These drugs help activate the PPAR-GAMMA receptor, which plays a crucial role in glucose metabolism and fat storage, ultimately enhancing the body's response to insulin. But I also want to think here, could metformin or sulfonylureas also be helpful when it comes to scarring alopecias? What about other diabetes drugs? Could they also be explored in a dermatological case for lipid production and lipid metabolism? Because there's also other studies that show that the use of metformin can help with scarring alopecias. Now, we can look at several studies here. Memorani and Karnik 2009. This case report involved a single patient with lichen planopilaris treated with oral pioglitazone at a dose of 15 milligrams per day for 14 months, and the patient showed clinical improvements within 2 months and a marked decrease in inflammation after 6 months, and also remained symptom-free for a year after just, using the drug for a course of 14 months. That's pretty impressive. The next study that we can look at is Bibergenova and Walsh 2012, and this is a case series which included 21 patients with lichen planopilaris, 2 patients with fibrosing alopecia in a pattern distribution, and 1 patient with frontal fibrosing alopecia. The patients received oral pioglitazone hydrochloride at a starting dose of 15 milligrams per day, which could be increased to 30 milligrams a day if there were no adverse drug reactions. 5 patients achieved full remission, 12 showed improvement, and 3 had no improvement, unfortunately, and 4 actually experienced adverse reactions leading to withdrawal from the study. And these reactions were mild. They included left calf pain, lightheadedness, and nausea, dizziness, hives, so it wasn't anything deadly, but nevertheless possibly uncomfortable. So remember, this is a diabetes drug, so if you ever do get on it with your doctor, try to monitor your blood sugar levels. If you don't even have type 2 diabetes, it's not a good idea to just go into this blindly because you could induce a state of hypoglycemia. Anyway, the next study being Spring et al. 2013. This study involved 22 patients treated with oral pioglitazone hydrochloride at 15 milligrams per day for 1 year. 3 patients showed remission with no relapse, so they actually stopped taking the drug and they, didn't have any further signs of lichen planopilaris. They actually had improvements from the drug. 5 had improvements with lower disease activity, so they were able to reverse the hair loss, but they still had signs of lichen planopilaris. And 4 experienced improvement but had relapses, and then they had a negative result. So we had 4 people who were actually getting results from using pioglitazone, but then when they stopped, they kind of relapsed and then they had further hair loss. Finally, we have Mesenkovska et al. 2015, and this is a retrospective case series which included 18 patients with lichen planopilaris and 4 patients with frontal fibrosing alopecia. Patients received oral pioglitazone hydrochloride at a dose of 15 milligrams per day for a median of 10.5 months. 16 patients showed marked improvements, 5 had stable disease, and 1 had disease progression, meaning they kind of got worse even being on treatment. Just 1 person though, right? So maybe in that case, the person would probably have to increase their oral pioglitazone intake to probably like 30 milligrams a day, going as high as 50 milligrams per day. But again, if you're just listening to me saying this, don't try this on yourself. Go to a doctor and get monitored because there were some adverse reactions in this study, right? And this included lower extremity edema, so they had fluid buildup in their lower extremities, some weight gain, right? So pioglitazone actually increases your glycogen, so it stores the glycogen, right, into your fat. So this is obviously going to make you gain weight. And then there was a resistant hypertension that could or maybe probably doesn't have anything to do with the drug itself directly, but it could. It very well could. So this is why you should be monitored. But for the most part, in the body of the literature, it seems oral pioglitazone is safe. Now, there are some controversies out there where they say, oh, well, this thing can potentially cause, bladder cancer, right? To my knowledge, from what I can see, it only involved rats at a very high dose, and in the studies where it was noted that, oh, pioglitazone is causing cancer, it involved very old people, people who were type 2 diabetic, and those people in and of themselves, they already had a higher, likelihood of developing that kind of bladder cancer, right? So it doesn't necessarily implicate oral pioglitazone to bladder cancer. But that being said, maybe in the future there could be some sort of experimentation with topical pioglitazone to help people, right? Because we do have topical metformin for other alopecia conditions that are related to lichen planopilaris. In fact, we can look at some case reports of topical metformin being used to treat central centrifugal cicatricial alopecia, also known as CCCA. One study titled, quote, Topical Metformin for the Treatment of CCCA, unquote, by Olaoluwa et al., presents 2 cases of hair regrowth after the use of topical metformin for CCCA. The study highlights that CCCA is a progressive scarring alopecia predominantly occurring in women of African descent. Metformin, commonly used for glycemic control in type 2 diabetes, has shown efficacy in improving fibrosis in fibroproliferative disorders through the activation of adenosine monophosphate activated protein kinase, also known as AMPK. The patients in this study experienced substantial hair regrowth after topical applications of 10% metformin cream over several months. So my question is, why are these type 2 diabetes drugs having some success in scarring alopecias? Well, both the PPAR-GAMMA receptor agonist and metformin have significant anti-inflammatory effects. Chronic inflammation is a key factor in the pathogenesis of scarring alopecia, like lichen planopilaris and its variant CCCA. Therefore, any drug that can effectively reduce inflammation may help prevent further follicular damage and scarring. However, this might be a secondary benefit, because the primary issue here seems to be the dysfunction of the sebaceous glands and various sebocytes. The inability of their PPAR-GAMMA receptors to kind of actually do their job and break down the lipids in the skin causes for there to be a toxic buildup of lipids, right? This lipotoxicity in the tissue. PPAR-GAMMA agonists like pioglitazone play a crucial role in lipid metabolism and homeostasis because they actually turn on the PPAR-GAMMA by agonizing it, right? When you agonize something, you're kind of making it more active. You're essentially telling the receptor, hey, do your fucking job. Go back to breaking down those lipids. In the case of the PPAR-GAMMA receptor, that's what the medication pioglitazone is telling it to do. In scarring alopecias, disrupted lipid metabolism can contribute to the pathological process. So, by improving lipid metabolism, PPAR-GAMMA agonists like pioglitazone may help restore the normal functions of the sebaceous glands and their hair follicles by reactivating PPAR-GAMMA receptors activity, and thus, from there, increasing the metabolism of the local lipids and essentially cleaning out the toxic lipids and reducing the inflammatory response from your body's lymphocytes. On the other hand, metformin helps with lipid metabolism primarily through its activation of adenosine monophosphate activated protein kinase, or AMPK. AMPK activation by metformin inhibits the synthesis of fatty acids and cholesterol by downregulating the expression of enzymes involved in lipogenesis, such as acetyl-CoA, carboxylase, and fatty acid synthase. And this in and of itself helps reduce the accumulation of lipids in cells. So it's actually fighting the buildup of this sort of lipotoxicity in its own right. So maybe there could be a case here to use a oral pioglitazone along with a topical metformin, or maybe a topical compound of metformin and pioglitazone at the same time, right? That could help people with lichen planopilaris. Now, I wouldn't use both oral metformin and oral pioglitazone because, again, these things both affect blood sugar, so using it at the same time can really, really impact your blood sugar levels and make them drop dangerously low. So don't play with that, especially if you don't even have type 2 diabetes. Again, go to a doctor. I think it would be possibly better, just my opinion, not a doctor here, but I think it would be possibly better to just use one at a time. So maybe oral pioglitazone first, and then maybe thinking about putting on topical metformin on the scalp, or maybe somehow getting a compounded version of, of a pioglitazone solution that you can put on your scalp, and then you can take oral metformin, or realistically just probably using both of them on your scalp. But I think it's more accessible for people to just get oral pioglitazone or oral metformin. But looking at the wealth of the literature, it seems like oral pioglitazone would be the first intervention in dealing with lichen planopilaris, at least in an effective sort of setting. So let's talk about scalp DHT, or just DHT in general, in the tissues surrounding the hair follicle. So the medical literature lets us know of two competing theories concerning DHT in the scalp tissues after oral dutasteride and even oral finasteride's use. The first being intrafollicular DHT, and this is DHT at the dermopapilla, or the base of the hair follicle. And then the next being scalp DHT. Obviously, DHT being in the broader region of the scalp. And then there's something else that I've also been thinking. I haven't been able to find a study on this, so I won't include it in the quote-unquote competing theories. But there is possibly a way to assess DHT levels in the sebum secretions of the scalp. So this would be DHT primarily coming from the sebaceous glands, which could possibly give us a good indication on how much impact 5-alpha reductase inhibitors can kind of change and modulate sebaceous gland activity. But in any case, let's just focus on the intrafollicular DHT, being the DHT levels around the dermopapilla, or the base of the hair follicle, and scalp levels of DHT. Now, we all know that one study, right? The Olsen et al. 2006 study. And this lets us know that between 0.5 milligram up to 2.5 milligram of dutasteride, scalp DHT is reduced respectively by 50 to around 80%. This study was done for only 6 months, so there's some debate if the 0.5 milligram dutasteride group could have caught up to the superior hair count number seen in the 2.5 milligram dutasteride group. It could be that it does, and the apparent superiority of the 2.5 milligram dutasteride group is merely due to the drug reaching a steady state concentration sooner, and thus having its positive effects realized sooner than the 0.5 milligram dutasteride group. And we can understand this pharmacokinetic and pharmacodynamic principle by examining the Ghislain-Coggs study on dutásteride's pharmacokinetics and dynamics modeling, where 2.5 milligram of dutasteride reached a steady state concentration in the blood weeks before the standard 0.5 milligram dose. In any case, we can confidently say that the superiority could be seen in the large differences in scalp DHT that was maintained in the course of the study, which kind of lets us know that dutasteride at either 0.5 milligram or 2.5 milligram or up to 2.5 milligram reduces scalp DHT substantially. And the real superiority, if we had to indicate anything, could possibly be in the fact that the 2.5 milligram dutasteride load had a greater difference in terms of its reduction in scalp DHT by a pretty marginal amount, right? You're dealing with about 80% scalp DHT reduction on 2.5 milligram dutasteride versus 50% scalp DHT reduction on 0.5 milligram dutasteride. So that difference was maintained throughout the course of the study. So that's kind of the direction where people are going in when they say 2.5 milligram is just better, right? And that's what the study is essentially showing, given its 6-month study duration limitation. Now, in my opinion, I would say that the 0.5 milligram dutasteride is enough in most cases, probably a substantial amount of cases, and the 2.5 milligram dutasteride is something like, if you really want to be sure, right, just perhaps that could be something to consider, right? 2.5 milligram dutasteride, that is a surefire way of knowing that, okay, you're going to get the most scalp DHT reduction you can possibly get given the clinical data that we have. So that would be for somebody who has a super sensitivity to scalp DHT. But again, I can't necessarily say that the 0.5 milligram dutasteride is completely inferior to the 2.5 milligram dutasteride when it comes to getting those hair counts, right? Because we know that in AGA, you just have to bring it down a specific threshold, right? You have to bring the DHT down to a specific threshold, and then the hair follicles can flourish and grow their hair. So if I had to bet, I don't think there are that many people who are so sensitive that they need 2.5 milligram to maintain their hair in the long term. So there could be a protocol that I could see where 2.5 milligram is tried for about 6 months to a year, and then from there the person drops down to maybe 1 milligram dutasteride or 0.5 milligram dutasteride. But in any case, go talk to a doctor. I'm not a doctor. Just be safe, because when you go to the 2.5 milligram dutasteride group, as it was shown in the Olson et al. 2006 study, that the group that was using 2.5 milligram dutasteride had a higher rate of sexual dysfunctions. I think around 10% to 13%. But in any case, let's look at the other theory, right? The intrafollicular DHT, being the DHT at the derma papilla or around the hair follicle. So I'm not going to be going too in-depth into this study, but there's a study by Yoshikata Hobo et al. 2023, and although it's retrospective in nature, it found that dutasteride reduced levels of intrafollicular DHT, being DHT at the derma papilla or around the hair follicle, by over 95%. So what did they do to get this data for this particular study by Yoshikata Hobo et al.? Well, it's retrospective, so that means they gathered pre-existing data. So they found men who were already using finasteride, already using dutasteride, men who were using either finasteride at one point earlier within a year and then dutasteride later, or vice versa. They were determined to be the dual finasteride-dutasteride group. And the researchers compared the levels of DHT that were at the base of the hair strand that was plucked out of the hair follicle, or, the white part, right? The derma papilla area. And from there, when they synthesized the hair follicle, they found the greatest reduction in DHT for the group that used dutasteride. For the group that was determined to have both dutasteride and finasteride detected in their hair follicle, it had about the same reductions of DHT as the group that only used dutasteride. So that being around a 95% reduction in intrafollicular DHT levels. So with all of this in mind, we must understand that losing hair while using oral dutasteride possibly points to a situation in which the problem may no longer be a sensitivity to DHT, but perhaps another issue here is causing poor scalp hair growth and scalp health. And there are many diseases of the scalp that can possibly cause that, right? Seborrheic dermatitis, psoriasis, lichen planopilaris, frontal fibrosing alopecia in a distributed pattern, which is fibrosing alopecia that gives a diffuse alopecia kind of look. Conditions like hyperprolactinemia, issues with your thyroid, vitamin and mineral deficiencies, which destabilize your body. Maybe even microbial life, which is wreaking havoc on your scalp, like folliculitis decalvans, where you have, bacterial colonies that inflame your hair follicles and cause scarring over time. There are so many other concerns that it rapidly becomes more likely that those issues that I stated out are probably a factor rather than you having a super sensitivity to DHT, such that even 20% or let's say 5% DHT left on your scalp can cause your hair loss. No, that is probably not the case. It's less likely that that is the case. And this is why you need to get a scalp biopsy. And people need to understand, right, when you've been dealing with a chronic scarring condition of alopecia, like lichen planopilaris, if you've been dealing with that for, let's say, 5 years, even if you treat it, it doesn't mean that the hair is going to come back, right? So, I've talked to people where they're like, oh, well, I got a scalp biopsy, I have DUPA, it says that I have lichen planopilaris, and I've been treating it for a year, yet I'm not getting any benefits. Did I really have lichen planopilaris? Well, yeah, you did, if that's what the biopsy determined, but also at the same time, let's be real here, right? If you had such a horrible condition of the scalp and it destroyed literal hair follicles, what are you asking for, right? It's very hard for any hair to come back in that condition. The only thing you can do or hope to do is to arrest the disease progression, right? To stop the progression of whatever's causing your hair loss and hopefully just kill it or remove it or limit it. Just stopping, right? Let's just be simple with the terminology here. Just stopping the bad thing that's happening to your scalp. And you can find out what that bad thing is by getting a scalp biopsy. And once you get that scalp biopsy, you get an understanding, right? You understand what could be contributing to your hair follicles just getting absolutely decimated. And then from there, you can possibly take drugs to kind of remedy that, right? If you're early enough and you catch your lichen planopilaris, let's say that's what you have, for example, it's a defect of the PPAR-GAMMA receptor, right? This receptor is responsible for metabolizing lipids. If this receptor is not working properly, it leads to lipotoxicity, and this causes your immune system to send your lymphocytes to infiltrate various tissues in your hair follicle, and it could lead to a destruction due to a mass inflammation caused by these lymphocytes as they're trying to destroy whatever's producing the sebum, either being your sebaceous glands, your sebocytes, etc., etc. And once this happens, this large-scale inflammation can potentially destroy your hair follicle. It can potentially destroy the stem cell bulge matrix area where the hair follicle stem cells are, which are very, very crucial for activating your hair follicles to even grow. Okay, so let's just be real here. If you have been dealing with that for years on end and you have that condition, taking something like pioglitazone hydrochloride between 15 milligrams up to 50 milligrams can reduce the disease, right? Can stop the disease outright in some people. But it doesn't necessarily mean that those hair follicles are going to come back online, especially when that stem cell bulge matrix area, that area that has your hair follicle stem cells, are destroyed. If that area is destroyed, those hair follicles are unfortunately a casualty of the war that the alopecia condition was raging on your scalp. And you just have to move on from that and possibly hope that the hair follicle stem cells are still alive in some areas, such that when you take something like pioglitazone to reduce the, let's say, again for the example, to reduce the lichen planopilaris in that area, that if that disease is gone or limited, that the hair follicle stem cells can replenish the hair follicle organ, and thus you get hair growth in areas that were being suppressed. So hopefully that made sense as we move on with this video. But I would also advocate looking at other sort of topical anti-inflammatories like calcipotriol, right? A vitamin D analog. So a sort of treatment regimen that I can kind of see right now, and I'm just kind of speaking off of script, would be something like, let's say, oral pioglitazone 15 milligrams a day, followed by clobetasol propionate 0.5%, used somewhat frequently, maybe for 2-week cycles, 2 weeks on, and then after that, not using that for like a month. And then using calcipotriol. Calcipotriol, I think it's at 0.005% concentration, using that somewhat daily, topically, right? And maybe for, just to see how things are, possibly a topical metformin, right? And the idea is to kind of target the inflammation as hard and as fast as you can, and still, over time, gradually dropping those topical treatments, right? Not using the clobetasol propionate solution every day. And then after a time, reducing the amount you use the calcipotriol, this topical vitamin D analog, which, as a side note, is used in conditions like psoriasis, right? It's used in psoriasis to kind of slow down the inflammation and get rid of those plaques as well. But it's also used in conditions like alopecia areata. So it's noted in its anti-inflammatory effects on the tissue. But at the same time, we also want to address the dysfunction here, which is the PPAR-GAMMA receptor being downregulated. So by using pioglitazone, you use it as an agonist, right? It sort of increases the activity of the PPAR-GAMMA receptor. So now you're actually regulating the lipid metabolism in the tissue properly, right? And you'd be taking this thing orally, But if you can possibly get it as a topical solution, maybe that could help mitigate side effects down the line if you ever are to experience them, right? So I think my estimation for a topical pioglitazone sort of solution would be between 2 to 5%. That's just my estimation. But also at the same time, a retinoid receptor agonist would possibly do well, right? So something like tretinoin, topical tretinoin, because you could have a weird case where maybe your retinoid receptors are downregulated and not working properly. And as I mentioned earlier, right, the PPAR-GAMMA receptor has to combine with the retinoid receptor or retinoid alpha receptor. So these two things have to come together in order to actively activate certain genes in your DNA that's responsible for metabolizing lipids. And it does this by going into the sebocytes and various other sort of cells in the hair follicle and skin structure in order to get rid of those lipids, right? But mostly from what I've seen in the literature, the scarring alopecia deals with a dysfunction of the PPAR-GAMMA receptor. So just to put this in plain English, pioglitazone, oral pioglitazone that is, 15 milligrams. From there, clobetasol propionate, and then the calcipotriol 0.005%, something like that. But again, go talk to a doctor. I'm not a doctor. I can't, prescribe these things, but I certainly can talk about the literature. Low-dose naltrexone, or LDN, has also garnered increasing attention as a potential treatment for inflammatory alopecias, particularly scarring inflammatory alopecias like lichen planopilaris and the other variants. There are several studies that I can just briefly mention that kind of explore its anti-inflammatory properties and its ability to modulate the immunoresponse system. So in Strazula et al. 2017, this study involved a retrospective review of 4 patients with lichen planopilaris who were treated with 3 milligrams of low-dose naltrexone, also known as LDN, daily. The researchers noticed a reduction in symptoms like itching and scalp inflammation, alongside a slowing down of the disease progression. Notably, in all of these patients, LDN was tolerated well without any sort of adverse effects. So this highlights its safety, but also LDN is pretty cheap. So, it's very cost effective when it comes to using it in the long term. Next, we have Hamill et al. 2023, and this was a prospective study that was open label with 26 patients. So Hamill et al. Demonstrated significant reductions in inflammatory markers, particularly erythema. And for those of you who don't know, this would be a redness of the skin. So it's a common sign of inflammation. Not the only sign of inflammation, but a common sign of it. So reductions in this particular inflammatory markers, among others, occurred over a 12-month span with the use of LDN. Now, this study did have a lack of a control group, and 26 is still a pretty small sample size. But if anything, this isn't a harmful sort of adjunctive treatment therapy for lichen planopilaris and FFA, or frontal fibrosing alopecia. So when it comes to the low dose, typically ranging between 0.5 milligram up to maybe 5 milligram, or even if you're pushing it, 10 milligram, it seems as if, this LDN has some therapeutic benefits. In the case report by Klein et al. 2022, this report described a remarkable instance of hair regrowth in a patient with lichen planopilaris who received LDN combined with platelet-rich plasma therapy, or PRP therapy. Now, beforehand, the patient had not responded to conventional therapies, so this kind of underscores LDN's potential to reverse hair loss in scarred areas and maybe even help the current treatment that someone's using be a bit more effective. So if you're working on reducing those inflammatory signs and markers through some sort of immunomodulatory effect through LDN, that could only benefit you if you have a sort of mild autoimmune inflammatory scalp condition. And I guess to some minor extent, you're always going to have a form of inflammation when it comes to androgenetic alopecia. It's not uncommon to see in clinical observations as well as in even biopsy reports where you do see signs of mild inflammation or perifollicular inflammation around the hair follicle. Hence the term perifollicular inflammation. But I'm going to take this back and use some of my own anecdotal experience, because I also use LDN, but it has nothing to do with hair loss. I use LDN because I have a chronic pain condition. I'll get into that later. But why do people commonly use, or not commonly use, but why is it becoming more popular to use LDN for chronic pain issues? Well, LDN has also been explored in this chronic pain sense because it has the ability to antagonize the toll-like receptor 4 or TLR4 on microglial cells, which can reduce inflammation and neuropathic pain. Or at least it has the potential to help reduce this sort of neuropathic pain and inflammation. And this mechanism of action makes it an attractive option for managing conditions like fibromyalgia and complex regional pain syndrome. The immune system is often misunderstood as solely a defense mechanism against viruses and infections. And while that's true, there's also other systems that it governs, right? And this includes things like wound healing, tissue repair, and maintaining a balanced inflammatory response. In conditions like autoimmune diseases and chronic inflammatory disorders, the immune system can mistakenly target the own body's tissues, as seen in cases of lichen planopilaris. In cases of lichen planopilaris, what do you have, right? Like I explained before, you have a buildup in lipids, which causes a lipotoxicity in the tissue. Your immune system is sensing like, oh man, you have a lot of this toxic stuff, toxic material in these tissues. Let's go in and destroy the tissue that's causing this issue, destroy the cells that are causing this issue. And in that process, it leads to a hyperinflammatory state, which destroys a lot of cells and a lot of tissue structure. So these conditions highlight how immune dysregulation isn't just about failing to fight off external invaders, but also it involves a response to internal signals, and the case in point being a toxic accumulation of lipids and cellular stress. So like I said before, LDN antagonizes the TLR4 or the toll-like receptor 4 protein, and this is a protein that's typically on immune cells like macrophages that detect harmful signals and trigger the release of inflammatory cytokines such as TNF-alpha or interleukin-6. So that's what the macrophages do, right? And macrophages, they go in there and they eat dead cells and they just kill them and poop them out. I'll just put that in some sort of rudimentary term for the audience. Cytokines are signaling molecules that regulate the immune response. But again, when you have an excessive release of those cytokines, it can lead to chronic inflammation. So LDN, low-dose naltrexone, like I said previously, blocks the TLR4, and it can lead to recovery or better odds of recovery for some pain conditions and even autoimmune inflammatory conditions or inflammation conditions rather, like lichen planopilaris. So this is something to consider, right? Throwing in LDN into the mix. Now, for me, like I said before, personally, I started using LDN to address a chronic pain issue from my trapezius muscles. And this injury occurred, I want to say sometime in August of 2020. And I was working out incorrectly, but also it comes from years of just holding heavy book bags or backpacks on my shoulders. And it kind of made that area very weak. And over time, it just made me more prone to injury. I'll tell you a story. I remember it was October 2020. I was walking and, when I stood up, I had this shooting, radiating pain going through the middle of my back and shooting upwards into my trapezius. It felt like there was like a saw or someone was cutting the nerve endings on my back, and it was like inflamed. You can see the size difference. It was really, really hot. Same thing with my trapezius. My trapezius felt like it was being torn from the insides. And then eventually, after forcing myself to stand up and walk for literally 30 minutes on end, just in pain, it just went away, which isn't often a good sign because if it kind of burns itself out, that means the nerves have reached a very high level of neuropathy. But I don't really have that much issues today. As of now, recording this video, I think for the most part, the pain is largely, just in the trapezius areas. And typically it's only triggered when I'm wearing things on my shoulders, like my backpack or, carrying anything heavy. But weirdly enough, when I do like shoulder presses or military press, if I really spam my trapezius with a workout or some sort of movement, and then I get a good pump, the pain goes away for like maybe weeks on end, right? But it's not something that I consistently deal with. But it's always there in the background. Certainly isn't as bad as it was back in October of 2020, but it's something that I'm kind of working on getting over. At the moment, I do physiotherapy along with taking my LDN, and I've seen significant improvement. I take my LDN before bedtime because of its unique ability to temporarily block opioid receptors, and it appears to enhance the release of endorphins and dopamine during sleep. So I guess when you sleep, these things are going to be released anyway. So when you take the LDN, it binds to those receptors and prevents the reuptake of it. So when it finally releases, it leads to you feeling more refreshed and the pain itself kind of goes away, right? So it's kind of playing on that kind of system as well. But it works for me. I don't want to use the anecdote that it works for me, but it really has. It has worked for me. But at the same time, LDN can give you some pretty weird dreams too. So just kind of be made aware about that. I have had some very, very vivid dreams. I had this one weird dream where my body turned into a Tesla and I went into a paperclip. Like I drove into a paperclip. I know that sounds fucking crazy, but seriously, hear me out. But no, that, you get like weird dreams on LDN. Some people do. That's a potential side effect. But in any case, it is very safe. Of course, go talk to a doctor. I'm not one myself. But it has, at least in early studies now, in early studies that it's being explored for, it has multifaceted benefits, supposedly. But it's still going through studies as well. When it comes to it being used topically, I'm aware of some compounding pharmacies that use LDN along with, let's say, topical finasteride. But what I'm interested in, and I'll just say this, because we're at the end of the video for the most part, and I'm just rambling on, but I'm wondering if LDN could be used with pioglitazone topically, right? If we were to make some sort of topical solution that compounds LDN at, let's say, maybe 4%, 5%, and pioglitazone between 2% to 5%, maybe if we deliver that topically for somebody that has an autoimmune lipotoxic inflammatory condition like lichen planopilaris, perhaps that can work on two fronts, right? First, you're addressing the PPAR-GAMMA dysregulation by antagonizing the PPAR-GAMMA receptor to make it work again and help metabolize those lipids in the tissue. But at the same time, you're using LDN to kind of modulate the inflammatory signals or the signaling from the macrophages, right? You're binding to the TLR4 receptor on the immune cells so you can slow them down from, releasing their cytokines, such as TNF alpha or interleukin 6. So once that's slowed down, the tissue can kind of repair itself and not be in this overinflamed state, not signal to lymphocytes that, hey, lymphocytes, come over here, continue the immune response. It kind of immunomodulates the tissue and helps the follicles potentially reach a more favorable state for hair growth. And then from there, maybe, as an add-on, possibly using calcipotriol or, like I mentioned previously, clobetasol propionate. Using all of that topically and trying to fight inflammation on various fronts and pathways, that would be potentially favorable for making the tissue come back to a regular state, right? Not making it become inflamed. And again, this should only be done, at least in my opinion, and looking at the literature, when you have confirmed lichen planopilaris. I don't think there's any harm in testing it out, again, under a doctor's supervision, because to some extent, you're going to have mild inflammatory issues with most alopecia conditions. But the philosophy behind what I'm saying is you have to be aggressive when it comes to targeting any sort of alopecia, right? Especially cicatricial, those scarring alopecias, because one, time is of the essence. So the longer the inflammatory response goes for, the more likely you're going to get higher rates of fibrosis and just destroyed hair follicles, right? So trying to get in there and stop that from happening is really, really important. Next, the other factor would be to, again, help the scalp come back to a state that is conducive for hair growth, and that, these follicles can actually start responding to treatments like dutasteride or finasteride. So that's my ramble for this. Hopefully this was a bit coherent. Maybe you guys can understand it, but of course, if there's any questions, that can go in the comment section below. So that's kind of like the treatment intervention that I can see addressing if somebody is to have their DUPA or retrograde alopecia sort of, diagnosed with a biopsy. And if that biopsy comes back as lichen planopilaris or some other condition, now you can effectively know how you would go about potentially treating it. And before I close up, now that I've given like a quick rundown, and believe me, I'm getting tired of talking myself, I just want to address something that I saw months ago on Reddit. And this concerns, well, what causes these lipids to build up? So, in a paper by some Reddit researcher, not to be disrespectful, this guy's an actual researcher too. This paper is titled, quote, "The bald phenotype androgenetic alopecia is caused by the high glycemic, high cholesterol, and low mineral Western diet," unquote, by Nicholas John Sadgrove. And the author explores the relationship between diet and androgenetic alopecia. So this paper suggests that poor glucose control and high cholesterol, which is characteristic of the quote-unquote Western diet, are significant contributors to the development of androgenetic alopecia. And then his article highlights that balding follicles demonstrate accelerated oxidative damage and increased fatty acid synthesis, with overactive PPAR-GAMMA receptors playing a role in these processes. However, this perspective seems to be somewhat backward in my opinion. While it suggests that high sugar diets may trigger androgenetic alopecia, it appears more plausible that individuals with androgenetic alopecia may already have defective PPAR-GAMMA receptors or produce high amounts of toxic lipids that their PPAR-GAMMA receptors cannot adequately regulate. These defective receptors could make them more susceptible to the effects of DHT and other metabolic disturbances, right? So remember this, DHT can cause the sebaceous glands to produce sebum that's high in triglycerides and cholesterol. And if that's happening and your PPAR-GAMMA receptor is kind of messed up and it can't adequately break down those lipids, this can contribute to having an exaggerated hair loss, which could be, developed into, let's say, lichen planopilaris, or perhaps, let's say, seborrheic dermatitis, right? You just agitate the overall environment, and then it creates a sort of feedback loop mechanism. Now, it's not to say that diet has no influence on this. I think maybe diet probably does have an influence on it, but let's be real here. It doesn't matter if you eat a high cholesterol diet or a high sugar diet. So it could be helpful for your overall health, but your androgenetic alopecia is going to be initiated and caused by DHT. So let's just be real with that. So this paper seems to suggest that, if you eat a Western diet, it'll start your androgenetic alopecia. No. It could make it slightly worse if you have issues with your PPAR-GAMMA receptor and you're intentionally increasing the amount of lipids and triglycerides in your body while your body can't even metabolize them properly due to that sort of defect. And again, that defect, the PPAR-GAMMA receptor, can just be due to, let's say, genetic issues that you already had with it, predisposed genetic issues, or maybe it could be due to environmental triggers and toxins, let's say like pollution, for example. There's much to be discovered on what is actually going on here. But in any case, I think it's way too simplistic to suggest that, if you just eat cholesterol or sugar-based kind of foods, it's going to mess you up. You shouldn't do that in general. You shouldn't eat a high sugar diet, a high cholesterol diet. You shouldn't, right? It's not healthy for you in general. So I guess in that respect, don't do it. But I think this study is kind of, missing the point, right? The sugar and the cholesterol didn't cause androgenetic alopecia. So let's be real here. So really, that's the end of this video. I'm getting tired of hearing my voice. So are you. I'm recording this at 4:57 a.m. on January 11th, 2025. So what can I say as a takeaway, right? Firstly, it's this. If you have DUPA or retrograde alopecia, here's what you do. If you're concerned about it, go get a biopsy and maybe a KOH test. Once you go get a biopsy, it'll show you whether or not your hair loss is solely due to androgenetic alopecia or maybe it's due to something else. When should you worry? Well, if you're not responding to something like dutasteride, if you're getting worse on dutasteride, like confirmed, like you've been on it for like 2 years and you're still losing hair, then I would say at that point, yeah, go get that scalp biopsy because that's very unusual. You should also be concerned if your area of hair loss is like very itchy, if it's burning, if it feels weird, if it has a weird look to it, if it's discolored, that suggests that you're probably dealing with something else like lichen planopilaris or maybe perhaps frontofibrosing alopecia, right? There is another condition that you're possibly dealing with. Maybe you're dealing with psoriasis. Maybe you're dealing with a very chronic telogen effluvium that is being caused by seborrheic dermatitis, right? There are so many things to elucidate here, but the first step for a person with DUPA and retrograde alopecias or any form of alopecia that isn't getting better on finasteride or dutasteride, the first step here would be to go get a scalp biopsy. You got to do it. After that, depending on the condition you have, you can explore different avenues of treatment that can possibly help you and make your hair recover. If not, slow the progression down or stop conditions like lichen planopilaris and autoimmune scarring alopecia. If you're found to have an autoimmune scarring alopecia, like lichen planopilaris, frontofibrosing alopecia, pseudopalliative Brock, pattern, fibrosing alopecia, whatever you call that one, then the solution there is to maybe consider something like oral pioglitazone, a PPAR-GAMMA agonist. But because this is a type 2 diabetes medication and it messes with your blood sugar levels, you should really do this under the supervision of a doctor. Don't do this on your own. Don't hurt yourself. But at the same time, if you're noted to have an autoimmune hair loss condition, whether it's a scarring one like lichen planopilaris or a non-scarring one like alopecia areata, please, please, please go to another doctor, go to a immunologist of some kind, any doctor that can assess you for additional autoimmune diseases. Because like we looked at the one Lancet study that we checked with Nathalie Conrad et al., it was noted that people with one autoimmune disease tended to have another. So if you unfortunately got lichen planopilaris, go get yourself checked for a possible another illness. That being said, you can use topical corticosteroids too. I think that's also present in the literature. It shows that that can possibly help the secondary issues of the inflammation. You can slow the inflammation down. So you really want to attack this lichen planopilaris issue on multiple ends, right? Using the oral pioglitazone to make the PPAR-GAMMA kind of function again, so you can do that lipid metabolism in the tissue and reduce the lipotoxicity of the sugars and fats, right? And then from there, you would want to consider using clobetasol propionate along with a topical vitamin D analog like calcipotriol, which, from my understanding in the literature, when you use both a glucocorticosteroid or corticosteroid, topical corticosteroid, along with a vitamin D analog like calcipotriol, it kind of combats the skin thinning caused by the corticosteroid. So it could be pretty useful here, just to consider those, right? So you kind of want to bring these things up to your doctor, talk about it with your doctor, and that's only if you have the reality that your DUPA and retrograde alopecia is due to lichen planopilaris, which can only be confirmed with a biopsy. If your biopsy confirms that, hey, you don't have lichen planopilaris and your retrograde alopecia and DUPA is due to, let's say, solely androgenetic alopecia and that there's nothing else there, then just give your treatment time to work. It's likely that you're rushing it, or maybe you're just a bit too late to treatment, but still, kind of give the treatment time to work, right? And it might also say, explore other avenues. Maybe you could be the person that your hair loss is due to a nutrient deficiency of some kind. But anyway, guys, that's what I want to say about DUPA and retrograde alopecia. Sorry for the long yap fest, but hopefully this video was informative enough. Hopefully we went through the literature to kind of show us where, okay, there are gaps here, and it doesn't seem like things are being clearly laid out for people who deal with these conditions. So I'm done talking. It's way too early in the morning, and hopefully this video can help people. Anyway, if you got this far in the video, comment in the comment section below. Hello and thank you. Anyway, see you on the next one. Bye.